The views expressed on the Jerry Cahill CF podcast are that of Jerry Cahill and guests, and not necessarily those of the Boomer Esiason Foundation. Nothing on the Jerry Cahill CF podcast should be considered medical advice. Such advice can only be given by a physician who is experienced with cystic fibrosis. The Boomer Esiason Foundation, Jerry Cahill and guests cannot be held responsible for any damage which may result from using the information on this podcast without the permission of your medical doctor.
Welcome to Jerry Cahill's Living, Breathe, and Succeeding podcast series, The Path Forward with CF. This show was made possible through an educational program from Columbia University Medical Center and the Lung Transplant Project to the Boomer Esiason Foundation. So now that you've been through the pre-transplant process and you're on the list, what's next?
Once a cystic fibrosis patient is listed, we would like that patient to maintain a steady exercise program. We certainly have had very motivated patients over the years who exercise on their own and they don't need to go to a rehab center. I know a couple of people. However, we do have patients who can use pulmonary rehabilitation just to initially monitor them and to give them a good exercise regimen, particularly those patients who haven't been exercising in the past. In addition to exercise, though, I always tell patients not to just sit on a couch and feel sorry for themselves, but get up and do things and always be active. Exercise is only 2 to 3 times a week, but daily activity is super important to maintain patient stamina. The other thing is good nutrition. It's very important that, especially in case of cystic fibrosis, that patients maintain their weight, and that's typically done with the use of nutritional supplements on top of food, and sometimes using medications to stimulate appetite. Lastly, another important component of waitlist preparedness is education. So I think it's essential for patients to be completely ready for transplantation and know what to expect, particularly if there are complications after surgery. The more the patients know beforehand, the better they'll be able to handle it. At Columbia University, the care team for a patient typically consists of a transplant pulmonary specialist like myself, one of the transplant surgeons who performs the operation and who would follow the patient later on if they develop surgical problems such as wound infection or airway complications, a coordinator who is typically a nurse practitioner or a physician assistant, so advanced level coordinator who works in tandem with the medical pulmonologist to provide care for a patient, and then the rest of the team, such as a social worker who helps arrange for home IV therapies or home physical therapy, the inpatient physician assistants who take care of the patients while they're hospitalized, either right after their transplant surgery or in the subsequent months or years. And then there are a lot of people in the background who the patients never meet, such as the radiologists, such as the bronchoscopy suite people that our patients actually do get to meet, but they're usually sleeping most of the time during their bronchoscopy. Our pathologist who interprets rejection versus infection in the samples we obtain during bronchoscopy. So there's a whole army of people that provides care to patients, some very visible and others less so. When the patients are first referred to our program, they typically meet the transplant pulmonologist and a pre-transplant coordinator in their first visit. That first visit is pretty long. It involves first our history taking, so asking patients a lot of questions about their past medical history, review of records, which is typically done before the visit, examination and assessment of their medical and psychosocial behavior. After that's done, we spend a substantial amount of time educating the patient about what transplant is. Typically, the coordinator starts that, and we obtain an informed consent for transplant evaluation. That is approximately 3 pages in length. So we review alternatives to transplant, what it means to have a transplant evaluation, donor selection, recipient selection, and other factors, and get informed consent. And then the physician takes over and takes the patient from the initial day of the visit, the first visit, to surgery and what happens after surgery. So it's a fairly long counseling session that may take about 45 minutes or so in addition to the medical visit. If the patient appears to be a reasonable transplant candidate, we also obtain blood and urine studies in that first visit. And then the next step would be to schedule the patient for the required testing that is typically done at our center over the course of 2 to 3 days. If the first visit goes well and there are no major red flags, then the person is scheduled for a more thorough evaluation that involves not only testing, but consultations with the rest of the team members, a psychiatrist, social worker, transplant surgeon, financial counselor, nutritionist, and so on, to make sure that they're thoroughly assessed as a potential transplant candidate. So they're not listed in the first visit. The listing decision comes after all the testing and evaluations are done. Many times patients ask what happens after they complete their transplant evaluation. And the first thing that happens after transplant evaluation is completed is a multidisciplinary team meeting in which we review the patient's medical details with the entire team. At that meeting, we make two major decisions. The first decision is this person a good candidate for transplant or not? If the answer to that question is yes, the second question we try to answer is when should that person be listed? Many patients we evaluate are not ready for listing. Either they're still too healthy and we decide to follow them over time, or they may have goals to meet. They may need to gain weight or lose weight. They may need to exercise. They may need to have more tests. So there may be some other goals for them to meet before they're listed. But typically, the reason why we would not immediately list a patient is because they're too healthy for active listing and they have a low lung allocation score, which would not grant them lung offers until they become sicker. Before transplant, patients are not required to be in the hospital, and many of our patients get called from home to have their lung transplantation. However, remember, we talked about the lung allocation system, and in this priority-based system, what's happened over the last decade is the fact that we have been transplanting sicker and sicker patients with very high lung allocation scores. And most of those patients with scores in the 70s, 80s, 90s are patients who are in the hospital on a lot of oxygen, non-invasive or invasive ventilatory support, or even support with a device called ECMO, which helps exchange oxygen and carbon dioxide levels. One of the problems with cystic fibrosis patients in the current lung allocation score system is the fact that they need 2 lungs replaced, not just 1 lung. And when they get assigned a lung allocation score, it tends to be lower than some of the other diseases that require a transplant. In other words, it's very hard to call them from home for a transplant when their score is in the 30s or low 40s, when there are patients in the hospital whose scores are in the 60s, 70s, and 80s. So unfortunately, they end up waiting longer and they end up requiring hospitalization and some of these support measures before they get a transplant. In terms of how long they need to be in the hospital, it all depends on how sick they are, how high their LAS is, and their size and blood type. Some people end up getting transplanted within 1 day of being hospitalized, and other people may end up waiting for 6 or 8 weeks on one of those support measures before a set of lungs becomes available for transplant. One of the questions we get asked is, when a patient gets called for a double lung transplant, do we call another candidate who could get by with a single lung transplantation? And the answer to that is typically yes. And the reason for that is in many times in a given donor, one of the two lungs can be injured due to pneumonia or trauma from a motor vehicle accident and may not be usable for transplant. And sometimes that is not obvious when we get the initial offer for donor lungs from all the information we get. So our team flies or drives out to the donor hospital, assesses the lungs carefully inside and out, and then makes a final decision about viability of both lungs. If they're both viable, then they're transplanted into the first patient who's waiting for a double lung transplant. However, if they find one lung to be unsatisfactory for transplant, then unfortunately we would have to send the first patient home and transplant the backup recipient or backup candidate with a single lung transplant. So as patients are being evaluated for transplant and they're listed, one of the main things that we consider is how strong is their support systems. And when I say support systems, that means people they're close with, could be friends or family members who are dedicated to helping take care of them. And that involves things like helping at home with household chores, shopping, food, cooking, all that stuff that we take for granted, helping with home medical care. It may be hooking up IV antibiotics, or if the patient is fully capable of doing that, that's fine, but many patients need an extra hand to do that. And then bringing the patients to their visits that are, quite frequent after transplant, at least in the first year, as well as bringing them to their bronchoscopies and other procedures during or after which patients cannot drive. So that's very important. The value of emotional support is also tremendous. I mean, I can't tell you the number of times I see patients totally overwhelmed with all the things they have to do at home, all the visits they have to come to. So having a supportive environment is tremendously important for keeping them on track mentally for post-transplant life. The main message I'd like to give CF patients who are waiting for a transplant is to learn about transplant, learn about potential complications, but do not focus on those and have a positive outlook, thinking that once you get a transplant, you're going to do better, your quality of life will be a lot better, you'll live longer, and what happens to you after that can be dealt with as long as we work as a team. And when I say team, I don't just mean the medical team, my team, but team as patients and healthcare providers combined, dealing with problems as they come by to make life better for that person. Sometimes our patients get paralyzed by hearing about post-transplant complications, the risk of rejection, infection, cancer, and they get overwhelmed, severely anxious or depressed. I just tell them, know the facts, but be optimistic. It's super important to be optimistic and work hard to remain healthy after transplant. So when I review transplant complications with transplant candidates before their surgery, they commonly ask me, is it worth doing this? And I think it's a fair question, but my answer to that is absolutely yes. We have to remember that we offer transplants to people who are at the verge of dying. They typically have survival estimated to be 1 to 2 years at the most. And many patients we transplant nowadays have days, weeks, or months to live without a transplant. So although transplant is fraught with numerous complications, there are many patients who do very well after transplant. And since in my mind, it's the only alternative that a patient has, it's absolutely worth doing and then dealing with problems as they come along. The clinical care of patients through experience, research is improving every year. The outcomes are stellar, and I'm happy to review the outcomes that we have at our center at 5 and 10 years, but they're stellar, especially in cystic fibrosis, so it's absolutely worth doing. And to see my patients go back to work, to see them produce, to see them educate and support other patients, to see them cycle, run, and do events is incredibly gratifying to me, and it gives me sort of more fire to tell them to continue, be optimistic, and go for transplant when the right time comes. It's definitely not worth having a transplant if the lung disease is not severe enough, but when the right time comes, it's absolutely worth going through a transplant.